But what we know so far is that it's the most heavily mutated version of SARS-CoV-2. It has about 30 mutations in the spike protein, 10 in the receptor binding domain in the S1 segment. These mutations, in a sense, have jumped much more forward compared to Delta, which was about 7 mutations in the spike protein. And according to the first attempts at modeling, that this virus will actually have a lower infectivity than the Delta variant, probably about a third or less of the infectivity.
Tamara Ugolini for Rebel News, and I'm pleased to be bringing you an actual expert on COVID-19. He is a medical doctor with experience managing infectious diseases and, among many other modalities, also a cardiologist investigating the complications of COVID-19 viral infection and the injuries that seem to be developing after the COVID-19 products. Here I bring you a breaking interview with highly qualified and hands-on Dr. Peter McCullough, who has been on the front lines of pandemic response since the onset. Let him introduce himself. Dr. Peter McCullough.
I'm an internist, cardiologist, and trained epidemiologist. I'm in academic practice in Dallas, Texas. I see patients every week, but I also spend part of my time in research and scholarship. And you have a deep background in clinical trials and evaluation of new medical products, data safety. And I'm the editor of a major journal and the president of a major medical society. In the last 2 years, I've dedicated all my academic efforts towards the COVID-19 crisis. And I've published the 2 major papers that are relied upon on how to treat COVID-19 as an outpatient illness to prevent hospitalization and death. And most recently, I have been very focused on the data safety monitoring and the clinical efficacy of the vaccine program.
Mm-hmm. Right. And I think many of our viewers can search out some of the other interviews that you've done in relation to that. Now, specifically for today, I wanted to touch on this new variant, the Omicron variant being recognized by the WHO, that's the World Health Organization, and how the mainstream media is now obviously churning out the incessant fear around this variant as though it presents a very high global risk. Now, based on what's known so far, what you know, the scientific and medical community knows thus far, how real is that risk for things like immune escape and severe lethality?
There are already early attempts to characterize the new mutated virus in terms of modeling the spike protein and understanding fundamental concepts of infectivity and virulence. And what we know so far, and of course this is a work in progress, but the independent scientific labs will almost certainly race much more quickly than the government or public health authorities. But what we know so far is that it's the most heavily mutated version of SARS-CoV-2. It has about 30 mutations in the spike protein, 10 in the receptor binding domain in the S1 segment. These mutations, in a sense, have jumped much more forward compared to Delta, which was about 7 mutations in the spike protein. And according to the first attempts at modeling, that this virus will actually have a lower infectivity than the Delta variant, probably about a third or less of the infectivity. And because the mutations have almost certainly interfered with the ability of the virus to dock and enter the human cells through the ACE2 receptor, we may see milder cases. The first reports that came out of Botswana, as well as in South Africa, 2 different doctors in South Africa conferred a couple of things. One, it appears to have arisen from vaccinated individuals. And number 2, it so far has exerted mild symptoms, which we would expect in vaccinated. We'll have to see how it works out in the unvaccinated individuals. And I think the other major observation is based on the mutations that we're aware of. A couple more things. One is that it'll give a unique PCR pattern where from the PCR we could infer that it's the Omicron variant. And that's because of what's called S gene dropout, meaning that the primer for the spike protein is no longer detectable by the PCR because it relies on an amino acid sequence is coded by base pairs that now is sufficiently changed that PCRs won't detect that S gene. The PCRs will be positive when, in fact, the virus is there and it's in a properly done PCR, but the PCR itself will give a pattern. The second inference is that almost certainly this is not going to be sufficiently handled by the vaccines. This probably Delta had exhibited considerable antigenic escape, but with this degree of mutation, almost certainly this will be completely escape the effect of the vaccines. And we know that because the vaccine manufacturers have immediately announced a turn to try to develop a product against this variant.
Is this part and parcel as to why it was so previously held that you don't vaccinate in a pandemic?
Yeah, that's exactly right. So, it was, many have advised, and I did as well, that it would be a blunder to try to do a mass vaccination in the middle of a global pandemic because there's too much prevalent virus. And so the virus is going to make mistakes when it replicates. In this case, it may not have been an evolutionary advantageous mutation. I think this is important to realize. With Delta, it clearly was evolutionarily advantageous because it was obvious Delta went from just a tiny percent of the mutations to 100%. So Delta was a huge evolutionary advantage over all the other strains. So Delta, in a sense, wiped out alpha, beta, gamma. And so Delta was a big change. This one may not. And already the early reads on the molecular structure of this suggest it probably won't wipe out Delta. Delta is so sufficiently successful in thriving in the nose and the mouth of the vaccinated. And we know that from papers by Reimer Risma from Wisconsin Department of Public Health, as well as Arian from UC Davis. And by the way, we have hospital outbreak data with Delta from Chow in Ho Chi Minh City, from Keener at the University of California at San Diego, Hetemäki from Finland. It's relatively clear that Delta can clearly infect individuals and vaccinated individuals can actually pass it to one another.
That the ability of individuals who are infected through breakthrough infections, namely vaccinated people who ultimately get infected, that they are generally without symptoms or minimally symptomatic. However, it is clear that they are capable of transmitting the infection to uninfected individuals.
One recent paper in Lancet suggested about 39% of all the Delta transmission occurred from fully vaccinated to fully vaccinated.
Wow. Now, to rein in the fear a little bit around the narrative that's being pushed with the Omicron, as more and more prophylactic treatments, and that are preventative measures, of course, they're being shown to be highly effective in reducing one's risk of adverse viral effect. But I guess not only just this virus, but all respiratory viruses. Tell me about this new and most recent finding of nasal and oral decontamination that anyone can do at home.
Well, one of the things we've seen progressively with each one of the variants is a higher viral load. Delta really took the prize for the highest viral loads, about 251 to 1,000 times higher numbers, in a sense, of viral particles in the nose and mouth of those who were infected. And it was the same for vaccinated and unvaccinated, certainly much greater than with other variants in the unvaccinated era. So this means that the virus, in a sense, multiplies to a great extent in the nose before it invades the body. And so that's the opportunity. And now we have data that have come in, an important trial by Chowdhury and colleagues, randomized 606 individuals to dilute povidone iodine or betadine in a solution where it comes in a 10% solution, it's diluted down to basically under a 1% solution, and then used as a kind of a deep spray into the nose and to sniff back and spit out, and then a gargle. And when that's done every 4 hours in the incipient phase of COVID-19, it markedly drops down the viral infectivity period, and it has a dramatic reduction on reducing hospitalizations and death, and actually the need for oxygenation. And that's actually with no systemic therapy. So you can imagine how powerful this would be. And in fact, clinicians are already leveraging this data from Chopra and colleagues, summarized a whole variety of studies showing literally just a few seconds of contact and the virus is killed, that this can be done on a daily basis when people go out of the house and they come back after being in a congregate setting just by way of routine once or twice a day. It can be done 4 times a day in an active post-exposure prophylaxis type of mode when there is a direct contact with a known patient who's sick with COVID-19. So we think this is going to be enormously important. The caveats are don't swallow the solution. If it burns, make it more dilute, because we almost can't make it too dilute because it's such a powerful therapy. In that if an individual has Graves' disease or active thyroid disease, Graves' disease or hyperfunctioning nodule, we'd stay away from iodine just like we would with someone who's got an iodine allergy or the pregnant woman. And we could switch over to dilute hydrogen peroxide and get a very similar effect. So we have oral nasal decontaminant strategies now. Our dentists have taught us to do this. I give them a lot of credit. And those overseas are using these treatments. There's a lot of local innovation. A lot of your listeners may not know in Finland, the Finland FDA equivalent approved a nasal spray actually many months ago that are antibodies directed against SARS-CoV-2. It's an antibody nasal spray. So there's a lot of innovation out there. Not much is heard about in Canada and United States and the EU and the UK. But I can tell you the rest of the world knows that the virus is actually spread and carried in the nose. It's not a hand infection. Hand sanitizer was a completely useless endeavor. Trying to wear masks on people who don't have the virus was useless. Just actually treating the virus as it's in the nose and mouth is really where the action is. I would say it's indiscriminate. It has to be as tolerated. I think of small children who couldn't understand how to do it. It would be impractical. It clearly should be applied to those who are still susceptible. So remember, if someone has not had COVID-19, the respiratory infection, they're still susceptible. If they've taken the vaccine, they're still susceptible because we know the vaccine doesn't stop transmission or doesn't really influence COVID-19 illness to any great extent. So those individuals still susceptible should do that, and they should be wary. If someone, for instance, goes to church, and when they get home, they ought to do a nasal oral decontamination procedure before they go on with the rest of their day. I mean, they have several days to catch up on it. The human body doesn't spread it instantaneously. I think this is very important. It's only spread when there's active symptoms. So the typical spread pattern is someone has active symptoms, they come in contact with someone else, they transmit the virus, then that next person takes another 3 to 5 days, and then they transmit it to another person. So each person has about 3 to 5 days to intercept that carriage and knock it out before they become symptomatic.
Mm-hmm. And thank you again for joining me, Dr. McCulloch. I think it's so important to get some of this censored and suppressed information out to the public. Just in closing, do you have anything else, any other message for the public who may be scrambling in fear because of the media?
I think the single greatest thing to keep the eye on is the fact that individuals who are older, who are still susceptible, meaning that if they took the vaccines back in December, January, February, March, they basically now are uncovered. The vaccines run out of their effect after 6 months. And so those individuals need to know the vaccines have not been adjusted to cover the Delta variant. And so they need to get into a mode of responding with the oral nasal decontamination when they go out in congregate settings, when they've had an exposure to somebody, and clearly when they're actively ill. When older individuals are actively ill, everybody over age 65, those over age 50 with high-risk features like diabetes, heart, lung disease, kidney disease, they should actually find a monoclonal antibody center and get an infusion of monoclonal antibodies. We have products by GSK, which I think is the best, Regeneron and Lilly now, and everybody should know where their monoclonal antibody centers are, and don't waste a day on this. Even if the symptoms are mild, go ahead and get an antibody infusion, and the doctors can kick in with the rest of the drugs and get the patients through the illness. This is proven to reduce hospitalizations and deaths. The only patients being hospitalized or heaven forbid dying with COVID-19 are those who receive inadequate early treatment.
Mm-hmm. Well, thank you again, Dr. McCulloch, for joining me, and I hope that we can have communication as things progress.
Okay, thanks for having me.
Dr. McCulloch has such a calm, rational approach. He knows that there are effective prophylactic and early treatment options available to prevent death, and severe outcomes of this respiratory virus. Get informed, find a healthcare professional who can advocate for you, and take your health into your own hands, because it's becoming clear that the bureaucrats at public health, with their catastrophic pandemic response failures, aren't doing it for us or you. For Rebel News, I'm Tamara Ugolini. If you want to deck the halls with support for freedom of the press and truth in journalism while supporting your favorite rebels, you can snag up some of our new swag at rebelnewsstore.com and give the gift that keeps on giving to your favorite lefty family members. I'm sure that they would love a Let's Go Brandon t-shirt or mug. You can find all of our new designs and get some Christmas shopping done from the comfort of your own home at rebelnewsstore.com. And don't forget to use